This lecture is about hemophilia, with a focus on inherited hemophilia diseases. This will give a general overview of the presentation, diagnosis, and management of hemophilia. Hemophilia is an X-linked inherited disorder of bleeding. Hemophilia is caused by defective production of coagulation factor 8, causing hemophilia A, or of coagulation factor 9, causing hemophilia B. Hemophilia A is more common than hemophilia B. There are female carriers, but they are rarely symptomatic. However, up to 1/3 of the patients may not have a family history and are due to de novo mutations of either factor 8 or factor 9 genes. Clinically, in patients presenting with easy bruising in early childhood, spontaneous bleeding, especially into the joints and soft tissues, and excessive bleeding following trauma or surgery, especially minor ones, should prompt the suspicion of hemophilia. In hemophilia, PT should be normal. APTT is prolonged in moderate to severe cases of hemophilia. But do note that in mild hemophilia, APTT may still be normal. Definitive diagnosis depends on demonstrating a low coagulation factor levels. As von Willebrand disease can mimic hemophilia A, von Willebrand disease should be excluded prior to making the diagnosis. Molecular testing for common gene mutations in severe hemophilia and gene analysis are important for family study, carrier detection, and prenatal diagnosis. Presentation for both hemophilia A and B is similar, and the symptoms correlate with the factor levels. For severe disease, the factor level is less than 1%, and patients usually present with spontaneous bleeding early in their lives. For moderate disease, the factor level is between 1 and 5%, and patients have variable severity of symptoms. They have occasional spontaneous bleeding and have severe bleeding with surgery or trauma. For minor disease, the factor level is more than 5%, and patients usually do not have spontaneous bleeding, but only present with severe bleeding following surgery or trauma. Generally, the patients present with bleeding into joints and soft tissue. The joints commonly affected are the knee, elbow, and ankle. Oropharyngeal and gastrointestinal bleeding and hematuria can occur as well. Less than 5% bleeding involves life-threatening central nervous system bleed. Musculoskeletal complications are one of the most common chronic complications affecting hemophilia patients. These include deforming arthropathy, chronic synovitis, contractures, and fractures. Formation of factor inhibitors is a concern as well. These are antibodies against the clotting factors. It occurs in up to 20% of patients hemophilia A following treatment. Development of factor 9 inhibitors is uncommon. Transmission of transfusion-related infections was high prior to the introduction of viral inactivation of blood products, and it is still a concern now. In Singapore, approximately 40 to 50% of patients with hemophilia have hepatitis C, while there is no HIV cases reported so far. Management of hemophilia is complex. Optimal management involves multidisciplinary care of hematologists, orthopedic surgeon, occupational and physiotherapists, dentists, and infectious disease specialists, among others. Involvement of patients and their family in the care is essential. They should be educated about the condition and general management and coping strategies and resources. Prenatal diagnosis and genetic counseling can assist patients with hemophilia with their family planning. In Singapore, all cases of hemophilia will be reported to the National Hemophilia Registry. The registry keeps track of the patient and is an important source of demographic and data collection. General principle of management includes prevention of bleeding. Prophylaxis treatment for severe hemophilia can prevent occurrence of most musculoskeletal complications and is generally started within the first 2 years of life. Early treatment of bleeding episodes is important, and this can be done at home even. Drugs and activities that would increase the risk of bleeding should be avoided. Vaccination against hepatitis A and B should be given to all patients. In patients with mild hemophilia A disease, tranexamic acid can be used for minor cuts and dental procedures, but its use should be avoided in hematuria. Desmopressin or DDAVP can be used for minor bleeding that fails to resolve spontaneously. It can be given either subcutaneously or intranasally. Factor VIII can increase up to 3 to 6 times with DDAVP, but repeated exposure may sometimes result in poor response. DDAVP is ineffective for patients with severe hemophilia A and typically has no value for patients with hemophilia B. For patients with severe hemophilia A and B, giving the deficient clotting factors to the respective patient is the cornerstone of the management of bleeding. These factor concentrates can be recombinant products or human donor-derived products. Table shows the general recommendation of plasma factor levels to achieve for various types of bleeding encountered in patients with hemophilia. It can generally be divided into mild, moderate, and severe bleeding, and their desired levels of correction are as shown. Patients with mild bleeding can be managed at outpatient and with home therapy. Patients with moderate and severe bleeding should be admitted, and factors can be given 12-hourly. Some patients may develop inhibitors following treatment, and this poses difficulty to treatment with factor concentrates. The presence of inhibitor should be suspected if there is a reduced response to the factor concentrates. Inhibitors can be transient even though the treatment with the specific factor concentrate is continued. These are low titer antibodies, and its level is less than 5 Bethesda units. Those patients with inhibitors titers of more than or equal to 5 Bethesda units usually have persistent inhibitors. Low titer inhibitors can be overcome with higher doses of factor concentrate, and the bleeding stops. Patients with high titer antibodies will need bypassing agent to stop the bleeding. These agents include recombinant factor 7 and activated coagulation factors such as factor 8 inhibitor bypassing agent. Immune tolerance induction therapy is a strategy that can be used for eradication of factor inhibitors. However, its use is limited here because of cost. Thank you.